Good morning and welcome to Grand Rounds. This is one of our named lectureships, and I want to introduce you to somebody who's an important part of the history of the Department of Medicine first. That's Dr. John Leonard. And he embodied some of the most important elements of the University of Washington and academics in general. This is a picture of Dr. Leonard, clearly in a different fashion time. And he was a delightful man. He had intellectual curiosity. He was an outstanding diagnostician. The house staff really, truly adored him. And most importantly, he really represented the spirit of camaraderie in academic medicine. He died tragically while enjoying probably his first family vacation as a faculty member at age 42 of an acute myocardial infarction in Hawaii. He was awarded the first Beeson Award by the House staff. It was awarded posthumously, and to my knowledge, the only person to receive that posthumously. And it's my pleasure to introduce a good friend of mine who is very similar to Dr. Leonard. Every year for decades, he probably wouldn't want to admit to decades, but he volunteered to attend on the wards as a subspecialist, but in general medicine, in July or August so that he could greet the new interns and house staff. He enjoyed working with them so much. So my friend Dr. Joel Finkelstein hails from the Midwest. He grew up in Ohio, and he's lost his Midwest accent and ways, but it still is true to his soul. He's been in Boston for many, many years, where he trained at Massachusetts General, and he's been an important figure in bone physiology, male reproductive endocrinology, and the effects of androgens on male physiology. He's published numerous articles, but equally importantly is the quality of his work. He's done seminal work on the effects of teriparatide, or PTH, on bone physiology and its clinical applications, the effects of bone on various aspects of male physiology, some of which he's going to review today, and numerous other particular activities that relate to physiology. He's published 7 articles in the New England Journal of Medicine, all of them first authored or last authored. The last thing I'll say about Joel is I've enjoyed many great laughs with him over the years. He's a great tennis player, and I've yet to beat him. He won't play me anymore, so I don't get a chance to see if I can ever beat him. So let me introduce Dr. Joel Finkelstein. Please give him a warm welcome.
Thank you very much for that very kind invitation. And this is really a special lecture to me because I feel really among friends when I'm here. I know a lot of people in this group, and when Brad invited me, I was really thrilled. So I'm going to talk to you today about androgens and estrogens, and the title is Estrogen, it's what makes a real man, and I hope to answer that question by the end of the talk. So I'm going to try to cover 4 major areas. First, we'll start with some background information about androgens and testosterone. Then I'm going to spend a lot of the time trying to define what is male hypogonadism. Next, I'll turn my attention to the role of androgens versus estrogens in the various components of the male hypogonadal syndrome. And finally, if you'll indulge me, I'm going to speculate about the role of estrogen and why it's developed in men from an evolutionary perspective. So unless you've been living under a rock, you've missed the fact that testosterone's been in the news a lot over the last 10 to 20 years, usually because of scandals like this occurring in well-known athletes. The first one that really hit the news was the scandal of Ben Johnson winning the Olympic gold medal and shattering the world record. Later, Tim Montgomery shattered the world record. Both of them later tested positive for anabolic steroids. Here's our friend Lance Armstrong and Floyd Landis winning the Tour de France, only to later have their title stripped because they tested positive for performing-enhancing drugs. And then in 1998, there was the famous assault on the record books in Major League Baseball, Mark McGwire and Sammy Sosa. There's Mark McGwire in 1988, 10 years earlier, looking as a sort of a callow young man. And there he is in 1998, when he sets the record. Here's a young Barry Bonds in 1991. And then 10 years later, when Barry breaks the record, that's what Barry looks like. Testosterone has an interesting history. It's been written about for many years. In fact, in ancient writings, there's recommended ingesting testicular tissue for the treatment of impotence. But the famous Austrian physiologist Charles Brest-Sicard did experiments in the late 1800s which were rather remarkable. He injected himself with testicular extracts from dogs and guinea pigs, and reported that it increased his strength, improved his intellect, relieved his constipation, and increased the arc of his urine. He was pretty much on target. But the most amazing experiments were done in the early 1900s by Leo Stanley. Now, Dr. Leo Stanley was the chief medical officer at San Quentin, and he injected testicular extracts and transplanted testes from prisoners who had recently been executed into other older prisoners. And he wrote about the benefits of this. He said, human experimentation in prisoners. In such a place, all men are treated alike, and live under the same conditions of food, work, and general surroundings. These patients could be under our daily observation, and the follow-up conditions were ideal. I sort of like to see what his consent form looked like. So testosterone was first isolated and characterized in 1935, so 80 years ago. 2 years later, went to human testing. Just 4 years after it was isolated and characterized, the three groups that did that won the Nobel Prize for it. So over the next maybe 40 or 50 years, most of the effort was in trying to take testosterone and develop what I call a truly anabolic steroid to separate the virilizing parts of testosterone from the parts that cause they're anabolic. So people wanted an agent that just increased muscle mass without being virilizing. And then in the last 10 to 20 years, the attention has been turning towards using testosterone for replacement in aging men. And during that time, the sales of testosterone here from 93 to 2000 went up 500%. And in the last 10 years, they've gone up another 2,000%. So even though this is not an approved use, it's really dominated the market for testosterone. This is occurring, however, in spite of amazing gaps in our knowledge. We don't know, actually, whether testosterone has true benefits in men. We don't know whether it improves physical function, reduces fracture risk, improves sexual function. And importantly, we also don't know whether or not it's safe. We don't know whether it's safe, particularly for the prostate, whether it causes prostate cancer or benign prostate disease, and whether or not it increases the risk of cardiovascular disease. And in fact, we don't even know what is a normal testosterone level. We don't know the level of testosterone at which adverse consequences occur, and we don't know whether testosterone itself or its metabolites are responsible for its major functions. I'm going to turn my attention to these two questions today and start out with the question of what is male hypogonadism. Several years ago, the Endocrine Society put out a clinical practice guideline about hypogonadism in men. And they started out with this definition. They said hypogonadism in men is a clinical syndrome that results from failure of the testes to produce physiological levels of testosterone and a normal number of sperm. Now that sounds like a good definition. I mean, it sounds right, in fact, to me. The problem is operationalizing it. What are physiological levels of testosterone? So although the definition makes sense, I don't find it to be useful in any particular way because we don't know what this is. So what are physiological levels of testosterone? Well, I don't use the word normal very often. I try to use the terms for testosterone as optimal or adequate. But the way the normal range is listed on your laboratory recs, it's a reference range, not a normal range. It's the range of testosterone, it's the levels of testosterone that are either 2 standard deviations below the mean or the 95% confidence limits below the mean of a presumably normal young population. So that approach assumes that about 2.5% of the population is automatically hypogonadal and doesn't consider the physiological consequences of any level. So whoever said that 2.5% of the population has levels that are inadequate for supporting function? It's the kind of the way like we used to define hyperlipidemia when I was a medical student. We used to say that a person's blood cholesterol level was high if it was 2 standard deviations above the mean. That was around 300. So now we define hypercholesterolemia not on the basis of 2 standard deviations above the mean. We look at the levels that are associated with an increased risk of cardiovascular disease. And I think we need to do the same thing for testosterone. We need to define it physiologically. What are the levels at which you start having adverse consequences? So what is this? So defining that is easier said than done. So let's start with what we can all agree on, what truly is a suboptimal level. If you lower the levels of a healthy adult man down to prepubertal levels, certain changes will inevitably occur. You get changes in body composition, reduction of strength, usually a loss of sexual function, and a number of other undesirable changes. So therefore, prepubertal levels are clearly suboptimal. We can all agree on that. But where is it along? And here's some examples. This is data from a control group of a group of men with prostate cancer who were given a GnRH agonist, which suppresses testosterone and estrogen reversibly down to prepubertal levels. And you can see that when you do that, you get increases in these are bone turnover markers. These first two here are markers of bone breakdown. These are markers of bone formation. But the skeleton revs up and you have a high bone turnover state. And because of that high bone turnover state, you lose bone, whether from the spine, the hip, or the total body, etc. If you measure it by QCT, which measures pure trabecular bone, you can see it more easily. So that's one thing that happens when you lower levels to prepubertal. You also get alterations in body composition. There's an increase in total body fat. That's largely in subcutaneous fat, and a decrease in lean mass. Okay? So, as I say, we know that these prepubertal levels are abnormal. The question is, if you take people from normal down to prepubertal, where is it along that spectrum that things begin to change? Is it here, here, here? That's what we're trying to find out. What is a suboptimal or an inadequate level of testosterone? And why do we even care? Well, the reason we care, or should care, I think, is that because men's testosterone levels do change with aging. About 20% of men over age 60 and 50% of men over age 80 have levels that are 2 standard deviations below the mean of young men. By that definition, using the reference range, 5 million men in the United States over the age of 40 are hypogonadal. But the question is, do these men have consequences of their levels, and therefore should they be replaced? So here's what happens with aging. This is from a study of 900 men. You can see as age increases, there's gradual loss of decrease in testosterone. But there's nothing like you see in women at the time of the menopause. You don't see this marked drop to levels that are close to zero. You just see a modest decline. And the changes that occur would be modest too. Now, this is changes in bone density with age. So there's a modest decline of bone density. There's also a modest decrease in lean mass and an increase in fat mass. So those things are occurring at the same time that testosterone levels are changing, estrogen levels are changing. The question is, are they linked? Do the changes in the hormones have anything to do with these changes that otherwise are similar to what one expects in the hypogonadal syndrome? So to address that question, we performed a study we call Hypogonadism in Men, or HIM. The objective of HIM was to determine the levels of testosterone at which adverse changes begin in a variety of physiological processes as testosterone levels are experimentally reduced. So what we did is we recruited about 200 healthy men between the ages of 20 and 50. They had no other sort of chronic illnesses, etc. They had normal hormones. They had normal calcium regulatory hormones and a testosterone level that was within what I called the reference range. And they went through the following protocol. They were all started on, they're randomly assigned to these 5 groups. They each got a GnRH agonist every 4 weeks to suppress their endogenous gonadal down to nothing. And then they were randomly assigned to get one of the following 5 add-backs, either a placebo, so that they remained with severely depressed gonadal or these different levels of testosterone. The 6th group got double placebo. They got a placebo for both the GnRH agonist and the placebo for the testosterone, so their hormone levels weren't changed. That's the control group. This went on for 16 weeks. We then measured a number of outcome variables. First of all, we looked at testosterone levels. We did measure these mostly by RIA, but we took about 20% of the population and confirmed them with mass spectroscopy. And estradiol levels, which were measured strictly by mass spectroscopy, which is thought to be necessary when you're looking at low levels. In terms of the functional outcomes, we looked at body composition, both by DEXA, which looks at lean mass and fat mass. And we also looked at body composition by CT scanning, which allows you to look at the fat mass and to compartmentalize it as to whether it's intra-abdominal or subcutaneous. We looked at markers of bone homeostasis. The study was designed intentionally to be too short to see changes in bone mass by DEXA. So the primary bone outcome was something called C-telopeptide, which is a marker of bone breakdown. Nonetheless, we did do DEXA scans, and importantly, we did CT scans. CT scans are much more sensitive than DEXA scanning for detecting bone loss because it looks purely at trabecular bone, and I'll show you those data in a minute, too. We looked at muscle size, muscle strength. We did CAT scans of the thigh, looked at the cross-sectional area, and then we did leg press as a functional correlate of that. Then we assessed sexual function, obviously by self-report. The data were analyzed in a couple of different ways. First of all, we analyzed the data by the randomization, but to be useful to clinicians, we also had a pre-planned analysis where we would regroup the patients, the people, based on their average levels of testosterone achieved at week 4, 8, 12, and 16, so that we could classify them in the way clinicians look at things. Clinicians don't look at patients and say, this is a person who has a dose of 2.5 grams of testosterone gel. Clinicians say, this is a guy whose levels in the hundreds or the 200s or the 300s. So we reclassified them to be what we thought would be clinically useful. And we did the same thing for estradiol. We then compared the changes in each of these groupings with the change in the double placebo group. So here's the classic table 1. The men on average were in their mid-30s with testosterone levels at baseline in the 500s. And these are the hormone levels in the men and him. You can see that with the various doses, the group that gets the placebo has severely low depressed levels of testosterone and estradiol. Importantly, estradiol is made from testosterone in men, most of it, so that if you lower testosterone levels, you have a concomitant decrease in estradiol. When you raise testosterone levels, estradiol levels increase progressively, as you see here. So you can see that the group that got 2.5 grams had levels of about 300, which is around the bottom of our reference range. The group that got 5 grams had a level that recapitulated their baseline levels around 500, and there's the double placebo group. So let's look at the endpoints. Each of these slides will be set up the same. On the y-axis is percent change, and in some of them it doesn't show up very clearly. And then on the x-axis I plotted the levels of the groupings in terms of levels of testosterone from 0 to 99, 100 to 200, 200 to 300, etc. Out here's the double placebo group here, and this group here is the group that these groups here have levels that are at or above their baseline. So let's look at body fat. When the body, and asterisks are things that are significantly different than the double placebo group. So you can see that the groupings that had levels of 300 to 500 or lower all had a significant increase in total body fat by DEXA. So these people are very close to their baseline level, so you don't have to decrease testosterone and or estradiol levels very much before you have an increase in body fat. In contrast, lean mass was preserved until one got to very low levels. We didn't see significant decreases in total body lean mass until the testosterone levels were below 100. Okay, there's a suggestion here, 100 to 200 also, but it wasn't quite statistically significant. If we look at the fat changes, now by CAT scanning rather than by DEXA, so with CAT scanning, once again, you can compartmentalize where the changes are occurring. There's a big increase in subcutaneous fat, and with subcutaneous fat, we see it at levels of 300 and below. Whereas intra-abdominal or visceral fat didn't show any dose response. The dose response was random. Okay? So none of this is different than the double placebo group. Thigh muscle area, again, showed a beautiful dose response with significant changes occurring at levels below 200, okay? But a nice linear dose response. And here when you get levels that are above 700, this group had an average of about 1,000. You see the anabolic effect that you expect, actually increased lean mass. Leg press strength nicely recapitulated the changes that we saw in muscle area. There's a significant decrease in leg press strength in these groups who had levels below 200 that correspond nicely to the decrease in muscle size. And as you get the testosterone levels go above baseline, the muscle strength goes above baseline. So it's a beautiful functional correlate of the changes in muscle area. This slide shows C-telopeptide. Again, C-telopeptide is the marker of bone breakdown. C-telopeptide levels increase significantly below 200 nanograms per deciliter of testosterone. Again, but it doesn't look like, it looks more like a continuum than a threshold. I didn't have the plot. We did N-telopeptide, which is another bone marker of bone breakdown. It shows a much sharper demarcation at around 100 or 200. Now again, the study was not powered to show significant changes by DEXA, and indeed it didn't. But the only reason it didn't show a change overall was because the double placebo group changed the same as the group that got single placebo. But notice the y-axis, there's only 1% changes. These are very tiny changes. You start seeing the suggestion that there probably is a dose response if you had a big enough sample size. Whereas by CAT scanning, where you can see much more significant changes in trabecular bone, we saw an overall analysis of variance that was significant, and there was a significant difference between the groups that got less than 200 and the double placebo group. So they actually did lose some trabecular bone. Sexual desire. The classical teaching with sexual desire has always been that sexual desire is maintained in men until you get to very low testosterone levels. Well, that's not what we found. We found quite a linear dose response in changes in sexual desire as you went all the way up to the reference range, up to about 500. So a lot of patients come to me and say, we stay at a level of 300, and we say, well, that's within the reference range we're used to, so it's not a problem. This suggests that people who have levels of 300 that complain of decreased sexual desire, at least some of them, have organic problems. Whereas erectile function did show, just according to the classical teaching, it was maintained well until you got to about 200, and then it dropped off, so much more of a threshold effect, this effect on sexual desire. And finally, PSA. PSA again showed a very linear dose response, going up to the middle of the reference range, but importantly, with PSA, when you raised testosterone levels above baseline, PSA didn't go up any higher. Lipids, there have been a lot of studies, including studies by the group here, have looked at lipids, the effect of gonadal steroids on lipids. That literature is really very murky. And I think the reason it's murky is because most of the studies use the patients as their own control. If we use people as their own control here, we would have concluded that LDL goes up. But in fact, so does the double placebo group, and there was no effect at all, no dose-response relationship at all between LDL levels or total cholesterol levels and testosterone. However, in distinct contrast, as you've lowered testosterone levels, there was this clear, very linear dose response with HDL levels going up. And that's we really think of it the opposite way. We usually think of testosterone levels going up and HDL levels going down. For LDL, we saw no relationship at all. So the point is, from all these dose-response relationships, they differ. There's not a one-size-fits-all definition physiologically for what is male hypogonadism, what is testosterone deficiency. If you're interested in erectile function or lean mass, you can get down to pretty low levels before anything adverse changes. Whereas if you're interested in sexual desire or PSA, they seem to show a linear dose response all the way up to the middle of the reference range. So there are various dose responses for these things. And I think this provides a framework for using something that makes more sense than just the reference range. So to summarize the HIM study, there are clear but distinct dose-response relationships between testosterone and a variety of measures. And I think a physiologically based approach to the diagnosis of male hypogonadism should both inform the design of future intervention trials and help clinicians to decide when testosterone administration is likely to be beneficial. So next I'd like to turn my attention to the question of what are the roles of androgens versus estrogens in the various components of the male hypogonadal complex. Remember I told you before, most estrogen or estradiol comes from conversion of testosterone. So when things change in the HIM study, you can't tell if it's due to the change in testosterone or to the change in estradiol because they're occurring together. So let me start this out with a case. This is David. David is a patient I saw when he was 40 years old. He was a former Olympic gold medalist. And he had become an international sensation when he was a young man. At the age of 20, he defeated a gigantic opponent by delivering a stunning blow just above his nose, causing the heavily favored opponent to lose consciousness. And here's David at the age of 20, very muscular, lithe athlete. Now, he wanted to make a comeback. So he had heard that he could boost his testosterone level endogenously and therefore avoid detection by taking an aromatase inhibitor. By lowering estrogen levels, it would decrease the negative feedback, cause his testosterone levels to go up. And he found an internet doctor, or maybe it was Dr. It was you, Brad, to give him an aromatase blocker. He started with testosterone levels of 575 and an estradiol level that was well within reference to 28. So he came to see me 6 months later, after starting an Estradiol, complaining of episodic sweats and a marked loss of libido. And at that time, his testosterone level was 1,800, his estradiol level was 2. And importantly, he looked like that. So What happened? Well, this causes chest pain when I show this slide, but not most people in the audience, so I'm not going to make you remember back to the whole steroid biosynthetic pathway because it caused chest pain to me too. I'm only going to have you focus on this part here, how you make estrogen. So estrone and estradiol, which are two of the major human estrogens, are made by conversion of what's called aromatization of androgen precursors, androstenedione and testosterone. That accounts for about 80 to 90% of the circulating estrogen in men. So what are the consequences of estrogen deficiency in men? The literature is full of a lot of observations. In epidemiological studies, for example, estradiol levels correlate with bone density and fracture prevalence. Unfortunately, the correlations are quite weak, and you can't determine causation from those studies. And importantly, when you do epidemiological studies, you really can't separate which is the effects of testosterone and estrogen because they're so tightly intermingled. The next line of evidence that's been used to suggest that estrogen has significant effects on bone has to do with certain men who have experiments of nature. There's been one man reported who had a defect in his estrogen receptor, so he had a null mutation, so he was resistant to estrogen. And there's about 4 guys that have been reported that have a mutation in their aromatase gene, so they don't make estrogen. And those men have severe osteoporosis. And that's been used as evidence suggesting that estrogen is important for bone. The problem with this is that's true, but it doesn't tell you whether or not that the defect in their bone as adults is due to a developmental problem due to the estrogen deficiency or due to an early adult bone loss. So if we're interested in the effect of estrogen in adult men, this model doesn't necessarily address that question. There have been a couple of experimental studies, one done at the Mayo, one done by our group, which we used manipulations, just like I showed you there with GnRH agonists, to selectively cause estrogen deficiency in men. And those models do suggest that there's a role for estrogen in men, but they don't allow you to look at the role of estrogen in other types of things like body composition. And finally, the final line of evidence that estrogen is useful and is important in men and bone is that fat mass increases if you treat men with prostate cancer with an androgen receptor blocker. So the androgen receptor blocker, so it increases less with an androgen receptor blocker than with a GnRH agonist. So with the androgen receptor blocker, you block androgens, but there's actually a compensatory increase in estrogens. Whereas the GnRH agonist, you get estrogen and testosterone deficiency. So those men have have estrogen levels, but functionally androgen deficient, suggesting a beneficial role for estrogen on fat accumulation. There's also a number of lines of evidence suggesting that estrogen may have an important role in sexual function in men. And it mainly comes from animals. If you mutate the estrogen receptor alpha and beta in mice, or if you mutate their aromatase gene, these male mice show no sexual activity. There's actually anecdotal reports in humans that estradiol level can restore some degree of sexual function in male and female transsexuals. And sexual desire, this is an experiment done here, did not differ between normal men treated with a GnRH agonist and testosterone, GnRH agonist and testosterone and GnRH agonist alone, given with testosterone and testosterone for 6 weeks. So this is a model that Dr. Bremner's group did years ago, trying to create a model of selective estrogen deficiency. The problem with that study just today is that the GnRH agonist, testosterone, was not very powerful, so it probably didn't cause severe estrogen deficiency. So to look at the role of estrogen in men, with this background, we decided to do a study that we call HER. So HER is Hypogonadism with estrogen removal. The objective of HER was to assess the relative importance of androgens versus estrogens on bone homeostasis, body composition, sexual function, and a number of other processes. The protocol for HER is identical to the protocol for him, but in this case, in addition to these testosterone replacement groups, they also got an anastrozole, a powerful aromatase inhibitor that blocks the conversion of androgens of testosterone to estrogen. So how do we interpret the data from HER? This slide shows the predicted levels of testosterone and estrogen. As we give it the doses of testosterone go up, we expect the T levels to go up. Because they get an aromatase inhibitor, we expect now not to see an increase in estrogen levels with the higher testosterone levels. And here's how the data are analyzed. You can see that if the testosterone, the him and the her study, they both took the same doses of testosterone, so we expect them to have the same dose, the same levels of testosterone. whereas estradiol levels would go up progressively because in the HIM study, because romanization is allowed, but be blocked in the HER study. So if you compare the HIM study to the HER results, those should show the effects of estrogen because they have the same testosterone levels but are discordant for estrogen. There's sort of three possible ways I thought the data could come out. If you have an outcome variable that's regulated purely by androgens, you should see the same dose response in the HIM and the HER study because the testosterone levels are the same, but even though the estradiol levels are different, they don't matter. We're saying that if it's due to estrogen, if estrogen doesn't matter, you see the same dose response in the HIM and the HER cohort. If an outcome variable is regulated by estrogens, in contrast, you see a dose response with the HIM study because the estrogen levels do change as the testosterone doses change. But when you block estrogen completely, you see the same change, either increase or decrease in all the groups, in spite of the testosterone levels. So the testosterone levels don't matter. This shows that it's purely regulated by estrogens. Whereas if you have an outcome variable that's regulated by both, you see a dose response in HIM and an exaggerated dose response in HER. In the HIM, you see it because of the estrogen effect and the testosterone effect, but the additional estrogen effect is shown in the HER study. So those are the three possible ways that we could see the data come out, and let's look at the real data. So this slide shows the testosterone and estradiol levels in HER. We did see the progressive rise in testosterone as we expected, and the estradiol levels were pretty well suppressed, but I do want to point out that here this group that got 10 grams of testosterone a day did have levels that were about 3.5 picograms per mil, these down here about 1. So there's an increase of about 2 to 3 picograms per mil with these high doses, and that may be important in some outcome variables. This slide shows the real data, not the hypothetical data, for the testosterone and the estradiol levels in HIM and HER, HIM in blue and HER in red. So the testosterone levels can have very well matched, and as expected, the estradiol levels can have very well mismatched. Again here, the estradiol levels go up a little bit, and in fact, I want to point out the placebo group. If you give just the GnRH agonist to the groups that gets in the HIM study, you have a level of about 3.5, and you can lower that from 3.5 down to 1 with the aromatase blocker. So there's a small difference here. The discordance increases as you increase the dose. So as if something's regulated by estrogen, you expect the discordance between him and her to increase progressively as you increase the dose. So let's look at the real data. In blue are the HIM data that I've shown you already, and now I superimposed on those the data from HER. Here you can see total body fat, and you see if it has a pattern that's really purely estrogen. It's sort of the same increase in total body fat, regardless of what the testosterone levels are. So here you have a group out here that has testosterone levels that average about 1,000, but in spite of that, when you block estrogen production, the body fat accumulation is the same. So testosterone deficiency is not what causes fat accumulation in men. When men are hypogonadal, it's estrogen deficiency that causes the fat accumulation. In contrast, if you look at lean mass, the dose response is the same in him and her. So the estrogen is unimportant there. That means this is purely an androgenic effect. This is the effect of testosterone acting as an androgen, not testosterone acting as a prohormone for estrogen. Subcutaneous fat clearly showed the estrogen-like pattern, just like total body fat. You can see these big increases even at high testosterone levels. Whereas intra-abdominal fat, which didn't show any dose response in the HIM study, it however shows a clearly estrogen effect here. When you block estrogen production, you have much bigger increases. And notice that the discordance increases progressively as the testosterone levels go up because the discordance in estrogen levels is higher and higher. So intra-abdominal and subcutaneous fat are estrogen regulated. Like the total body lean mass, not surprising, muscle size is regulated by androgens purely, and so is leg press strength. And finally, bone resorption by C-telopeptide has the mixed pattern. You see a dose response in him, and you see a dose response in her. So in her, if there's a dose response, remember, the estradiol levels are supposed to be all the same, so that the difference between the testosterone levels, but it's exaggerated. You get an exaggerated increase in the HER study. But I do want to point out, notice here that the group that gets a placebo that has prepubertal levels of testosterone here, when you block estrogen down from 3 down to 1, you get a further increase in bone resorption. So to me that suggests that this apparent effect of testosterone on bone resorption should go up, maybe due to the small increase in estrogen that's occurring in in this group as the testosterone levels go up. So it implies that for both, at least for the skeleton, that very small amounts of estrogen are important in regulating bone turnover. And that's actually been shown in women. So let's look at the DEXA data. In him, we didn't see much of anything by DEXA in the lumbar spine, but when you block aromatization and you block estrogen production, suddenly you see a significant amount of 2% loss of bone in just 16 weeks. So again, estrogen, although for bone density, clearly estrogen has a very important effect. We saw a very pronounced effect of estrogen deficiency on bone loss, trabecular bone loss from the lumbar spine. So to me, this is giving the pattern that you probably possibly show an effect of testosterone on bone resorption, although I can make a case that even that's due to estrogen. For bone density, we saw only estrogenic effects. Sexual desire, this was the big news. This is what probably got into most of the newspapers. Sexual desire, we saw the dose response in him, but when you block aromatization, you have a marked further decrease in sexual desire. Now that shocks people. So estrogen plays a very important beneficial role on male libido and sex drive. It also helps with erectile function. That was predicted by the data in the mice. And remember, the estrogen receptor knockout mice, male mice, had no male sexual behavior at all. So Mother Nature sort of played an interesting trick on us. It turns out that androgens are very important for libido in women, and estrogens are very important for libido in men. PSA was regulated strictly by androgens, okay? You see the same dose response in the him and the her study. HDL was regulated strictly by androgens. Again, the same dose response in the him and the her study. Whereas LDL wasn't regulated by either. And finally, leptin, again, surprisingly, shows an androgenic pattern. And that's surprising because leptin is made in fat cells, and fat goes up, so you'd think that it was due to estrogen deficiency. So I would have predicted that leptin would be related to estrogens, but we saw exactly the opposite, a purely androgenic pattern for the regulation of leptin. And insulin resistance, which didn't show any dose response in the HIM study, HOME-IR is a sort of a poor man's model of insulin sensitivity. But insulin resistance goes up with estrogen deficiency, so there's a marked further increase in the HOME-IR. So this table, next table, is basically just summarize the data. Body fat is regulated, the fat compartments are regulated strictly by estrogens. Lean mass and muscle size are regulated by androgens. Bone turnover may be a mixed function, bone resorption, but bone density was regulated only by estrogens. Erectile function and sexual desire were regulated by both. PSA and leptin by androgens, and some other things I didn't show you. We saw no effect on blood pressure. So everything that estrogen does for men is good. It prevents bone loss. It helps maintain libido, erectile function. It prevents fat accumulation. It's estrogen deficiency that's bad in men. So why did this occur? Why is estrogen so important for men? Well, I think, if you'll indulge me, I think the answer has to do with what estrogen deficiency is designed to do in women. Evolution only cares about reproducing, surviving until you can safely nurture your young, and then we can die. So why does estrogen play such a major role in the regulation of bone resorption, fat accumulation, and sexual desire in men? My guess is that in this case, men are sort of an off-target or collateral damage for estrogen deficiency in women. Now, the menopause doesn't exist in evolutionary terms. We're not meant to live to be 80 years old. We're meant to die at the age of 25 or 30. In fact, in the 1900, the average life expectancy of a woman in the United States, a Caucasian woman was 50, and a non-Caucasian woman was 40. That was just 100 years ago. So we've invented the menopause. That's not the model of estrogen deficiency that's useful to understanding why estrogen deficiency might do what it does. The model is lactation. And many women are estrogen deficient when they lactate. And why is estrogen deficiency beneficial during lactation? So I argue that estrogen deficiency is an adaptation that is necessary to provide minerals to mineralize the newborn skeleton. When a baby is born, the skeleton is only 10% mineralized. Otherwise, you couldn't get through the birth canal. So that you have a soft skeleton, so to speak. It's not really a skeleton. Then after birth, it's got to get mineralized. Where's it going to get that 90% of minerals? It can't get it from anywhere but the mother's skeleton. That's where all the calcium and phosphorus is. So I think that evolution designed a system whereby when you're estrogen deficient, the skeleton releases its calcium and minerals to go into the breast milk to nourish the baby so the baby's skeleton can become mineralized. That's perfectly fine if you're not going to live to be 80 years old. Because if you're going to live and then die when you're 25 or 30, it doesn't matter. You're never going to develop osteoporosis. Osteoporosis doesn't exist in evolutionary terms. It's a modern invention. How about the increase in body fat? Well, in evolutionary terms, you don't go to the supermarket to buy food. You're a hunter and gatherer. And that's hard. So you want to have the energy stores to survive, to provide for the baby. So it makes sense to store energy as fat. It's the most concentrated source of calories. So a lot of women will tell you when they're pregnant and after they deliver, they get an accumulation of lower abdomen body fat. And that makes sense because it's an accumulation of stored energy to provide for the newborn child. How about the other classic symptoms of estrogen deficiency? Vaginal dryness and loss of sexual desire. Those would be adaptations that would be useful if you have one child and to deter you from having another child, well, then it's hard enough to provide the nutrients, etc., to the one child. So I think that those things develop from estrogen deficiency to help prevent a new mother from getting pregnant and having another child until she has safely gotten that child to be big enough to survive on its own. So, the take-home points. There are distinct dose-response relationships between circulating testosterone levels and various outcomes. Those dose-response relationships can be due to testosterone, or they could be due to its conversion to estrogen. But I think that information should help clinicians interpret the relevance of testosterone levels to symptoms in individual patients. Although the study didn't address the efficacy or safety of testosterone, it should help determine who should be included in studies. And although unraveling the effects of estradiol may not have therapeutic implications directly in many cases, understanding the mechanisms by which agents act often leads to new therapies. After all, estrogen is what makes us Superman. Thank you. I want to thank, I've had a wonderful group of people I've worked with, both physician collaborators, a fabulous biostatistician, a researcher, an administrative assistant that I can't live without, and great mentors, but particularly the research assistants. And what I'm most proud of is that there's something like a dozen or so research assistants on this project. And so far, they've all either graduated from medical school or enrolled or applying right now. So they've really been an important legacy, and they've done a fabulous job, and we couldn't have done the study without them. So I'll be happy to take questions. Yes?
Well, that was a great talk. I'm curious to review this data that, of course, was done in younger men versus older men. Do you think these thresholds would be the same if you did this study in older men? And particularly because you're really looking at decreases in hormone levels in this particular paradigm. If you did this study in older men, the deltas would be different.
Well, the question is, do the data in young men apply to the data in old men? There's some studies looking at high levels of testosterone administration that suggest that the dose responses are the same when you go up the dose response curve. It's super physiologic. We're actually repeating the study in old men now. We've done about half of the men recruited. So we'll have the definitive answer. But I think they're going to be pretty similar from what I've seen so far, just anecdotally. But that is important, because to apply these data, to use the data to make decisions about the treatment of men as they age with testosterone levels, you really need to do it in the older men.
I also thought that was a beautiful presentation up here, and very clever experiments to kind of unravel the cause and effect relationships of androgens and estrogens. And obviously these are short-term effects of estrogens. And I'm wondering, in clinical care, we're talking about long-term administration of testosterone and the longer-term clinical consequences. So where are we? How is this translating into trials and clinical outcome data for older patients?
Well, the question is, do these data, these short-term data, apply to long-term? That's a very important question. Obviously, you can't do this experiment. About 16 weeks is the longest you can do it because you're taking healthy men and making some of them severely hypogonadal. And we've done that for years, but this is about as long as we feel it's safe to do. I think with longer-term data, there might be a couple of things differences. Number one, most of these relationships are not threshold relationships; they're continuum, and you might be able to find what levels at which the risk decreases might be pushed further to the right to higher levels as you get longer-term data. Importantly, with long-term data, I'm sorry. Well, so we can't do much more than that, but I don't think that the long-term data there's any specific reason to believe that they'd be qualitatively different. I think the differences is just where the cut points are. I don't think you're going to see a difference in whether or not it's estrogens or androgens. I think that's very clearly answered from the short-term data. It's just a question of where along that continuum you use it. I think these data are useful short-term for deciding who to put into long-term studies. And the long-term data therapeutically will have to be answered by not the deficiency model, but the administration model. Yes?
That's an incredibly important talk. What's your personal take on all the flurry of news and concerns by the FDA and all over the internet in terms of increased cardiovascular events in elderly men treated with testosterone?
I knew someone asked that question today. So the question is, there's been in the news recently, there's not just testosterone in the news, there's 3 studies that have been published in the last 6 months or so that have suggested that there's cardiovascular risks that are significant. First of all, I don't think that they're all observational studies. One of them is a meta-analysis. One is a study that actually some people are asking to be retracted from JAMA. There's one in the +1. I don't think that you can answer the question from observational data any better than it's answered right now. I think in order to advance this field in terms of harms, one will have to have data from a long-term prospective trial that looks at these things and collects the data properly. I think with observational data, we've pushed the limits as far as we can. One of the studies, I think the meta-analysis is, I'm not a meta-analysis fan. They took like 2,000 papers and analyzed 27 of them. So you always have the problem of selection bias when you have these large meta-analyses. So I think you can make the data of a meta-analysis show anything you want. The study that was in JAMA, it was so awful that I was going to call the editor and ask them how they published it. There is actually a group trying to do that and have it retracted. The data, there's enormous errors in the data. There's 1,000 of different types of assumptions that are made. I don't think it's worth the paper that's written on, to be quite honest. I think you can make that data show anything. The one in +1 is the one that's the most, I think, likely to be valid. But again, these people as their own controls in the +1 study. It's so observational. If there were really severe risks, we probably would know about it, even from anecdotes from people taking anabolic steroids all these years. There's millions of men that take enormous doses. But I don't think we know. It's a huge public health issue, because you're talking about giving testosterone to 5 or 10 million men. You've got to get it right. This is the situation that we were in with the Women's Health Initiative a decade ago. And we know a lot more about women and hormone replacement than we do about men. We know virtually nothing. But we need a men's health initiative. Nothing short of that will answer your question, in my opinion. Yes?
Chestnut here, Joel. Excellent review and excellent studies. You're much too young to remember in the days of Formatrix, which was a combination of estrogen and androgen that Wyatt Thirst had, and there were thoughts about using it for osteoporosis. Based upon him and her, this may or may not have been of value. Your thoughts, though, now 50 years after that?
So I do have a lot of thoughts about that. In today's world, the similar issue is developing non-aromatizable androgens, or SARMs, selective androgen receptor modulators. So people have tried to separate out the androgen effects and the estrogen effects. And several of the SARMs These are SERMs is a drug called raloxifene that has certain effects that are like estrogen and some effects that are unlike estrogen. It binds to the estrogen receptor and it recruits a different group of different factors, and so we have selective effects. We thought that the answer to the long sort of standing search for the perfect anabolic steroid would be a selective androgen receptor modulator. But it turns out that they've been failing in development. Two major companies have already, at least two that I know of, have discontinued their programs. And I think the reason they fail is because it's a bad idea to get rid of the estrogen. I think that everything estrogen does for men is good. But when you lack estrogen, I think you're going to increase the risk of bone loss and loss of libido and fat accumulation. So I think they had it right years ago when they were giving testosterone and estrogen, or just testosterone, which allows itself to be made into estrogen. But you don't want to have just androgens in men. Pure androgens do not sound like the right idea to me.
Joel, thank you for an excellent talk. Sort of as a follow-up to Dr. Lipkin's question, the one thing that gives everyone pause is the reductions in HDL that are seen when you administer testosterone to a hypogonadal man. And your data nicely shows that when you take it away, the HDL goes back up. What do you think the mechanism of that is, and why is it different in men?
I don't know why androgen deficiency raises HDL. I don't know that I've never seen anything that specifically went after the mechanism carefully. I'm sorry, I don't know. And the question is, but I'm not sure. I doubt that it's really different in women, though. And that's the one thing. I doubt that it's really different in women. A lot of the confusion in this area has to do with uncontrolled studies. Like if you do uncontrolled studies where you give testosterone, you can show effects on LDL. That happens in Peter Snyder's study that it was the bone study that he looked at lipids too. But when he had a control group, then you see that the effects are the same in the control group and the treated group. So I think that it's particularly true for lipids. I'm not convinced by any studies that use patients as their own controls for assessing the effect of cannabinoid on lipids. You really have to have an independent control group. Yes. Yep. No, you. Oh. Right.
So I'm wondering what is the effect of giving estrogens to men who are currently being treated with for prostate cancer.
Exactly.
And in the old days, of course, when there was the old trials where people with prostate cancer were given estrogens and they didn't do well, but they still had lots of androgens around. But now you've got all these men with no androgens. Does that put back some of theirs?
That's the grant I'm starting to write right now. In the old days, people gave diethylstilbestrol, which was a very powerful estrogen, and people had vascular disease, cardiovascular disease events. But this data predict the levels of estradiol, which I didn't show you, which tends to occur around 10, maybe 15 picograms per mil. Okay, so most of the outcome variables, if it's like below 10. So if we give back 10 or 20 picograms per mil, I would predict that we can mitigate a lot of the fat accumulation, almost certainly mitigate the bone loss and loss of libido in these men. So when you ask about long-term studies, you can't take the things away long-term. So we came to the same conclusion that you did. For our next project that we're planning on doing is to give estrogen to men starting GnRH agonists for prostate cancer. It should be safe in terms of the prostate disease to begin with, but it also, I think, in low doses that are safe, should mitigate the side effects. And that would prove the estrogen hypothesis, take it full circle. Okay?
Thank you very much.
Thank you very much.